For various assemblies, we got a lot of entries on the birth certificate.
Not trusting.
Should I be able to hear the room? Because I can't.
There it is, 9:35. We were on mute. Hopefully now, can you guys hear us, Andrea? Perfect. All right. It's 9:35. This is Greg Clauser. I would like to bring this meeting to order today on the 29th. First thing we'll do is we'll take roll. Sean Parkman, I see you're here. Hello. Cindy Flowers. Andrea. I see.
Present.
Line. Kimberly is here. Siobhan, I see. Dawn is here. Emily Wang.
I'm here.
I see you online. And I see you, Rep. Nose. Good morning.
Good morning.
So we'll just watch for Chicky to come in. We have plenty of board members today. So we have, if we need to do any voting, we have quorum. And with that, I will turn it over to Ali.
Yeah, thanks, everyone. First, just wanted to take the opportunity to thank our various RFP teams. This includes staff, our board members, the DOJ, our Mercer team, everyone committed obviously countless hours to ensuring that this RFP process was conducted with integrity and according to our rules. I think Representative Nose stated this quite well in the past when marveling at the volume of work that really goes into.
Yes.
I'll never do it again. Once was enough in my lifetime.
That's right.
A lot of work.
Yeah, very well said. I think, I haven't even mentioned the proposers, the amount of time that they put in, unbelievable to, answer all of our, hundreds of questions and specifically would like to thank our contracts team, for keeping us all in line. I think, that's obviously the most important thing. And speaking of that, wanted to go over a few talking points with board members and staff following decisions announced today that will continue to keep us all in mind. So we'll send you all copies of the talking points after the meeting today, and please feel free if you have any questions or need any assistance. So first, even though the board selected winners announced or going to select winners announced at today's board meeting, the RFP communication rules will still remain in effect. We expect to have RFP related discussions at 2 upcoming board meetings. We plan to present the high level options and strategies for the board to consider in meeting the statutory 3.4% cap at either the May board meeting or June board meeting, most likely both. We then plan to present final plan design and rates information for approval at either the June board meeting or the July board meeting. Importantly, board members and staff should not discuss the RFP until the resulting contracts are substantively negotiated and the board has approved plan designs and rates. And we may, however, share today's board presentation that will be posted following. We'll let you all know when it's posted, by the way. All proposers, including ASPs, should continue using the RFP single point of contact for RFP related communications that are not specifically requested by PEBB staff or Mercer as part of implementation negotiations. And then lastly, please let PEBB's RFP staff know, this is Brian Olson and Sheila Clausen, if any proposers contact you regarding the RFP. Any questions on that? We'll send these out after the meeting then. And yeah, let's kick it off.
All right. At this point, it looks like we will be turning this over to Brian. Are you doing the presentation?
We're going to have Mercer's going to run the presentation, and I believe Ruby is going to initially kick things off.
Okay, so at this point, we will turn it over to Ruby.
Hello, thank you. My name is Ruby Castaneda, and I've been the lead for the most part on this RFP. So just as a reminder, just to kick things off, like a little bit of housekeeping, we ask only board members, Mercer staff, and staff to add commentary. If you are not board member, staff, or Mercer staff, to please refrain from adding commentary or clarifying anything unless we really need you to. But for the most part, we really want the engagement from the board members. And with that, I will let Emery or Andrew go ahead and get started.
Thanks. I can kick us off here. So if we could jump to 2 slides, please, Emily, to the agenda. All right, so here is our agenda for the next couple of hours to discuss the results of the RFP. And so we'll start with a quick refresher on kind of how we got here. So the development process for the RFP, the questionnaire, scoring rubric. We'll do that section somewhat quickly because I know you all are pretty familiar with the work that has happened over the past 2+ years. We'll briefly review some accomplishments today, as well as talk about some changes that have happened within the current carrier ecosystem. We'll talk about where we are at with regards to how the scores played out in terms of why continue with the RFP at this point. And then we'll start to actually look at the scores in earnest. And so board members, you all have seen the scores from the questionnaires. We will now be bringing in the scores from the finalist interviews, showing you a more inclusive score from each of the proposals. We'll talk about selecting winners based on those scores, and then we'll wrap up with so what happens next type of discussion towards the end. So this next section, again, I'm going to do somewhat quickly, only because I think that board members, you're all kind of familiar with how this development process has played out, and you have seen several of these slides in the past. But that said, just interrupt me if I gloss over something, or if you want to make a comment or pose a question, please do so. You can jump to the next slide, please, Emily. So we started talking about this RFP way back in 2023. It was in the retreat in November of 2023, where we did some exercises and really attempted to tease out what PEBB board members' priorities would be with regards to what you want to accomplish with this RFP. And we've attempted to capture that at a high level with these colorful bubbles here in terms of the key goals of the RFP. Then starting in 2024, we began having monthly discussions on specific topics that were specific functions that a health plan or pharmacy benefit manager would be performing on behalf of PEBB. So I'm sure you recall some of these. There were behavioral health and pharmacy and network access. And so each of those monthly topics was really intended to be a deep dive into that specific functional area. And the result of those was a position statement for each of those functional areas, which we then used to write the RFP. And so once we had those position statements on each of those key areas, we began writing the RFP, which was the first maybe 8 or 9 months of 2025 before releasing the RFP in late 2025. So the other way that we use those position statements, as well as these high-level goals that you're seeing here in these colorful bubbles, was to develop our scoring rubric. And so this was done in advance of releasing the RFP. So if you want to jump to the next slide, please, Emily. This is a quick refresher on the weighting for scores for the written portion of the proposals. And so we had different questionnaires. You can see we've got the medical questionnaire on the left, pharmacy on the right. The weighting between those two questionnaires are 80%, 20% between medical and pharmacy, which roughly matches the distribution of claims costs within your rates. And you can see based on, again, PEBB stated goals with this RFP, as well as the position statements, that's how we determine the weighting for the individual services or functions, which are these rows. And so there are a couple other pieces that don't have their own row, things like health equity, which really is kind of interwoven in all of these other topics. And so as we're going through the weighting and doing a refresher on the weighting of the scoring, it gets a little bit complicated because at a certain point, we're talking about percentages of percentages. And so later on in this presentation, we're going to show you an example, kind of how that plays out. So especially as I flip to the next slide, which I think we can do now, you'll see what I'm talking about. So like we have these percentage distributions within the written proposal. Now we're bringing in the finalist scores, which is a different percentage, right? And so when we think about an all-inclusive score, we've got 75% of weight on the written proposals and 25% on the finalist interviews. And so again, if that is like, for me, that's a little bit hard to understand without seeing a specific example. And so we will get there. As we get to the actual scoring section, we'll show you how that plays out. Okay, I think we can proceed. Thank you, Emily. And so this slide talks about the structure of the RFP. And one way that we've been describing this throughout the process is that there are kind of several mini RFPs within the larger RFP. And so this structure slide on the left, you can see we have one of our air quote mini RFPs is the statewide proposal. And so this is the broad-based PPO that is analogous to the current Providence statewide plan. We do have some requirements that were established before the RFP was released, which you can see in these bullets. And so these proposals had to be on a self-funded basis. There were options to submit either a combined medical pharmacy proposal, medical only, pharmacy only, and the board has the option to select up to one winner for the statewide RFP. Compare that to the box on the right, where we're looking at the regional proposals, and these are, instead of a broad PPO, these are the coordinated care models, and so these are similar to the current Providence Choice Plan, MODA Plan, and Kaiser plans. The requirements associated with this mini RFP at a very high level are the funding basis could be either self-insured or fully insured. Again, proposers could submit a combined medical pharmacy, medical only, pharmacy only. Unlike the statewide bid, the board has the option to select multiple winners in a given region, one winner in a given region, or no winners in a given region. And so a little bit more flexibility, and we'll talk about that when we do an overview of the regions here in a bit. Any questions so far? Okay, and so here is an overview of the regions for the CCM side of the RFP. And so we have these 6 regions of the state. And again, bidders could bid on any of these regions, all of them, one of them, 2 of them, et cetera. And similarly, board members have flexibility with regards to selecting a winning bid in terms of the number of bids in a given region. We did that intentionally. You know, if you look at the Portland metro area and the I-5 corridor, you know, this is where lion's share of PEBB membership is. This is also where in the state there's the most competition from a provider perspective. And so there could definitely be a reason to select multiple proposers in those regions, for example. Yeah. So any questions so far before this is all, I know, stuff that you've heard before. So I think at this point, Brian, if I'm not mistaken, I'm going to hand it off to you and you're going to talk about some of our accomplishments to date.
You're on mute, Brian.
Thank you, Andrew. Next slide, and I apologize in advance. My voice is a little hit or miss. So these are the RFP milestones. We reviewed or went over them last time when we asked the board to select finalists. It describes all of the milestones we've accomplished, you know, from development all the way through tallying the final scores and rankings, following the finalist interviews, and best and final offers. Next slide. Okay, on the next slide, we just see a little indication of where we are today, and it's the Q2. The star is gone, Mercer. We had a star indicating where we were right around business award. So Q2 2026, that's what we are doing today. Next slide, please. Okay, as many of you already know, Providence withdrew their proposals from RFP consideration after the board had already selected their proposals for finalist interviews. As a result, there are fewer options from which the board to select under this RFP. The RFP would and does allow the board to invite other proposers to participate in the finalist interviews, so long as those invites are made consistent with the RFP rules and the various proposal scores and rankings. However, Mercer and PEBB staff working on the RFP did not think this was advisable due to how the other proposals performed on the questionnaire portion of the RFP. We have identified some additional operational considerations to discuss today relating to the fact that there are fewer options available under the RFP than what we had expected. So these operational considerations include ensuring that Member disruption is minimized. Overall cost of the various plans selected in this RFP are acceptable to PEBB, and that the various plans selected under this RFP taken together are as consistent as possible with the current collective bargaining agreements that include differences in member premium cost share for more expensive and less expensive plans. And just a note, no additional board action is needed, just to stay with the finalists that have already been selected. Next slide, please. Okay. These operational considerations are not factors that will determine who the board will select as winners. All of those rules are already teed up in the RFP, with the RFP explaining in detail how everything is scored, ranked, and ultimately selected. However, once the board does select winners under the RFP, it may require that these important areas of negotiation are negotiated to PEB satisfaction with the selected winners before executing the resulting contracts. So what could these items look like? So one negotiation item could include requiring a winner to update their plan design, plan rates and financials, and network to ensure an adequate distinction between, the statewide PPO plan and the various regional plans that are selected. Requiring a winner to agree to various changes, including to propose plan designs to limit cost increases to 3.4% as required by statute. And to also require winner to agree to submit a specific plan on how maybe certain network gaps would be filled. Okay, next slide, please. Okay, so given fewer choices than expected, I think it begs the question, why should we continue with the RFP? At a high level, continuing with the RFP makes sense given the fact that even with Providence dropping out of RFP consideration, the situation isn't much different than if we were in the renewal process. There is a financial benefit in proceeding under the RFP, which Emery will get to when we preview the rates and financials. And the RFP's new contract will include several improvements over our current contracts. Next slide, please. Okay, so this slide is fairly similar to the chart we showed when we asked you all to select the finalists for finalist interviews. We've already completed steps 1 and 2, and those details are included in the appendix. So as you can see under step 3, we're going to update all of the proposal scores. And what we'll do is we'll take the highest RX only proposal, highest scoring RX only proposal. That score will be coupled with all of the medical only scores that we receive to have a updated compiled list. We'll start out with statewide in step 3, where we'll update all of those scores and rank them. We'll then move to a regional, and using those updated proposal scores, we'll rank the list of regional proposals within each region. We will then ask the board to select the winners based on the scores and rankings, and we'll do it based on how the RFP was divided up. We'll first go through the statewide PPO selection process and discussion, and then we'll move to selecting and discussing options for the regional CCMs. Step 6 is new. That was not included in the finalist interview flowchart. And that is just a note that when we select the winners, we will also have the board identify important areas of negotiations that need to be addressed to our satisfaction based on these important considerations that I just described. So next slide, and I believe Mercer, you are taking it back over.
Okay. Thank you, Brian. So what we're going to go here is really talk about how we calculated the points that you're going to see on some of the later slides. So this is essentially the totaling of various elements, the written questionnaire, which, as Andrew mentioned, we had presented in prior meetings. That is being weighted at 75% of the final score. So the written portion that, the scores we presented before, essentially multiply by 75% to get to a point total. Then we add to that the finalist interviews. So the gross score of the finalist interviews is based on 100 points. So you can get up to 100%. Not, based on their answers, they might not get a full 100%. In our example, we say they have 60%. But since the finalist interviews are a quarter, 25% of the total final score, essentially you multiply it by 25. So that 60% times that 25 gets to 15 points. And so those two elements, the written portion and the finalist interview portions, get added together. And that's the combined final scores that we're going to be showing later on in the presentation. So hopefully that makes sense. We do have some slides, again, that kind of show some of the breakouts and the appendix. When you get it, you can see the various elements as well. But I just wanted to pause to see if anyone had any questions about how we're getting to the final rankings. Okay, let's move on to the next slide. Brian, I believe this is you again.
Okay, so we're now going to preview the final scores for steps 2 through 4 in the previous slides. We are not going to ask the board to make decisions the first time we run through these results. When we do run through them initially, we've highlighted the proposal or proposals that the board may consider selecting under the RFP rules to illustrate the board's options, or in some cases, a lack of options. We've also presented the rates and financials related to these selection options to illustrate what the starting point will be for financial negotiations. And please note that the rates and financials that we'll present today are based exactly on how these offers were proposed. It's a starting point. Once we select winners, the board has the ability to direct PEBB staff and Mercer to further negotiate rates and financials with the winners to a point that's acceptable to us before being willing to execute the contracts. When we go through all of that preview information, or once we go through it, we will then start back up at the top and we'll go through steps 5 and 6, where we formally ask the board to select winners and to identify those important areas of negotiations. Okay, and Mercer, it is back to you.
Okay, so our RX proposals based on the updated score. So what we're when we talk about the RX proposals, basically you have the written portion, right? And again, those were provided before, and those were the points provided there. And then we add the finalist interviews to get to the final total RX written score portion, or not written score, final points. So the way the RFP is set up is you could provide proposals that were medical and RX combined, and there were plans that did that. But you could also provide a medical only option, and then your score would be combined with the highest RX only option. And so once you do that, you combine those scores. You compare them between those that are med only with the highest RX score, or those with a med and RX, to kind of get to the final rankings. So there's going to be multiple versions of essentially the same type of plan. For example, I think Moda provided both options, so we will be showing versions of that. Kaiser only provided the med and RX, so they'll only have one version of those types of plans. But all of those options are ranked together. And so that ends up getting to the final area. So in order to determine which RX plan gets put in with the med only, we have those rules down below. Basically, it's going to be the highest scoring proposal, unless there is a lower scoring proposal within 1% of the total score for the RX. And that proposal is from the Oregon Prescription Drug Program, or OPDP. So that's the only exception process. If OPDP is within 1% of the points, then they can be put in as the highest, essentially the RX proposal to be combined with the med only ones. Otherwise, it's going to be whatever. It's going to be the highest RX only proposal. And we did have 3 RX proposals that made the finals interviews, if you remember. One of them was OPDP, but then the other 2 was Med Impact and Capital RX. Okay. Any questions about the process? Okay. Well, then let's move on to the next slide. And so this is the, Brian, you want to take the slide or how do you want to do this?
No, we have Mercer. You're running through all of them until the very end.
Okay, all right. So you're gonna be hearing from me for quite a while. Okay. So RX, this is the RX only proposals. So you can see the ranking of the 3. We have the written portion of the scores, and that's carried over from the prior. And those actually were updated based on the BAFO. So we did request the BAFO. So that's the final offer. And so we did change those scores. And then the finals interviews are in the second column there. And so those are based on essentially the 100%, the total points. And then you take 75% of the written plus 25% of the finals interviews to get to the overall written and interview score. So you can see in green at the top, Capital RX has the highest total score of 79.1. Second place was OPDP at 73.1, and Med Impact came in third at 66.6. And so essentially because Capital RX is the highest scoring and it's beyond that threshold for the exception process, it is the plan that we're going to be including as the RX only option to be included with the Med only options.
And just a note, there's no board action for this. The RFP rules set it up. So since the additional criteria to select the lower scoring RX only proposals don't apply, Capital RX only scores are automatically coupled with the medical only scores from those medical only proposals.
We do have the total points out of 20. So when we're combining it with the Med only portion, like the Med only providers.
Representative Nos, I see you have a question.
Yeah, I think it probably gets answered when you talk about what's going on with medical, but Kaiser would never do this.
Yes.
Well, yeah, in the RFP, so we did not require that proposers on the medical side submit medical only. We encourage them to, but for example, Kaiser only submitted combined medical pharmacy proposals.
Okay. I'm trying to think of how I realize this is probably going to get revealed, but like you could see where potentially one of the medical people said a different one, not Kaiser, would want to also be the main medical be the main prescription drug provider as well, potentially.
Sure, some of them may want to, but again, the RFP laid out how everything would be mixed and matched, ranked, and then selected.
Okay, I'll wait.
Yeah, we'll get to your point, Representative, when we get to the slides, and we'll try to highlight that for you. Okay, so just for the purposes of combining the RX only with the Med only, the total points out of 20 because this is the RX portion. You can see on the right, so that's the written plus total score times essentially 20. So essentially 15.8 points will be added to all of the Med only options to kind of get to the overall score for them. Okay, any other further questions before we move on to the next slide? Okay. So statewide proposals based on updated scores. So we're going to go through the statewide proposals. And if you recall, basically you can choose up to 1. And so as a result, the highest scoring proposal is going to be the one that the PEBB board has the option of selecting, unless there are a couple of potential options here. Lowering score proposals within 2.5 points and meets at least one of the following criteria. Advocacy program and navigation scored higher and within PEBB's budget, or disruption is going to be 5% less than the higher scoring proposal. So this is going to be, as we go through this, basically you would need to see that, the options that the lowering scoring proposal had for advocacy and navigation is different and scored higher. So that's one of the ways to do it. And the other way is to have less disruption based on the networks that were provided. As we go into the next slide, we have a breakout. So at the top, we have the medical portion of the scores, and then the RX portion of the scores are down below. So we did break this out because because we wanted to show what each of those elements were. So for the medical score at the top, would be the finalist interviews for the MODA statewide, including just med only or that with the combined med and OPDP. And then we had the interview scores for MODA CCM, med only and with med and RX. So while you can see those two scores are the same for each of those because that's the medical portion of the question at the finalist interviews, you can see the MODA statewide PPO scored higher than the CCM, 71.2% of the points compared to 64.8%. And so that combined with the medical points from the written portion gets you to the final score. And so you can see that the differential is about 59.8 versus 58.2. The RX portion of the score for the two combined options, so that would be the MODA statewide med and OPDP RX, as well as the MODA statewide med and OPDP RX. You can see their finalist interviews because we did ask them questions about their pharmacy. Some of it was, were questions that all PBMs were asked, and there were specific questions that were asked of each PBM for their proposal. So that's why the finalist interviews are a little bit different because some of the questions were a little bit different.
And just to avoid confusion, for MODA's combined medical pharmacy proposals, they offered OPDP as that pharmacy component. And that is in addition to OPDP proposing as an RX only.
So, yeah, go ahead.
Thank you. Could you remind me what CCM statewide is versus statewide not CCM?
Yeah, so this is actually a question that we had in the finalist interviews. So MODA offered two versions of the statewide plan. One, the standard, essentially the PPO, the offering with the current statewide benefits was the MODA statewide offering. The CCM statewide offering essentially melds that with the CCM benefits in the plan, which they would call essentially the MODA plan. So depending on who you saw as a essentially primary care, if you saw MODA 360 primary care, or if you saw non-MODA 360 primary care, it would then essentially give you different plan benefits. So you would actually get more plan benefits. You would get the MODA, the coordinated care benefits. You went and saw MODA 360, but if you didn't, then you would end up with the statewide plan benefits.
The CCM is like managed care version versus the.
Essentially, yeah. It's the managed care network version, yes.
And it's two separate proposals.
Yes.
Separate, so this is an or, not an and.
Yeah, this is an or. Because, it's an or because we're talking about statewide, which only allows up to one winner.
Yeah, their two proposals, or the two types of statewide proposals they submitted, are competing against each other. And again, that was something we allowed under the RFP, right? If folks had other ideas on submitting different kinds of proposals, we didn't want to stifle any of those ideas.
Thank you.
Okay. So again, for those combined med and RX, there was a RX portion of the score. You can see that there. If I'm trying to remember correctly, the capital RX portion of the score, I think it was like 15.6 or 0.8. So that would be the points added to the med only, which is, I think, on the next slide. So yeah, okay, 15.8. So this is the all four scores combined with medical and RX. So the medical portion of the scores from that top table on the prior page are in the first column, and then RX scores are in the second column. So capital RX scored 15.8 points. The MOTA statewide RX portion of the med plus RX got 14.6. The med and RX portion, the RX portion of the combined med and RX CCM statewide scored a little bit higher at 14.7. But once you add up all the totals of the medical and RX scores, it ends up being that the MOTA statewide with capital RX, so that would be the MOTA med only option paired with the RX only option, is the highest scoring proposer. Because the advocacy solution and the networks were the same between all of these, there was no, criteria that essentially made it higher, better, and therefore we're not, those exception criteria that were provided on a couple slides before cannot apply, and therefore the number one score, the option that's available to the PEBB board is the MOTA statewide med only with capital RX. Well, it was a bigger, it's 2.5, but the advocacy was the same, and the networks were the same between all of them. Okay. Yeah, so the networks are the Connexus networks with the Aetna wrap. So there's no difference between the options. Any questions or comments? All right. Okay, let's move. Oh, Rep knows. Does that help explain the question to your question?
I think so. So bottom line, the statewide proposal, based on the criteria going forward, assuming MOTA and Capital RX accept the contract, is MOTA will be the medical provider, and they will have to work with Capital RX to figure out if there's any coordination that's required around prescription drugs.
Yes. Yeah. Yeah, there's definitely going to be coordination.
Rather than them being able to use their own thing.
Yes. Yeah. Yep.
Okay.
All right, let's move on to the next slide. Okay, so the next section talks about the regional proposals. So regional proposals are for each of those locations in Oregon that we broke out, or essentially the entire state. You can choose more than one. That's the option to the PEBB board. It doesn't have to be one. And especially in locations where there's essentially an offering plus the membership that would allow for some essentially competition and like differentiation, that could be to the PEBB board's liking to offer more than one plan in those regions. But in terms of the options that the PEBB board can select, essentially it's a very similar to what we talked about for statewide, but there are additional criteria, exception criteria. So the first two are the same ones as statewide. So the lower scoring proposal has to be within 2.5 points. And this is to jump ahead of like a higher scoring proposal. Has to be within 2.5 points or percent or points. And the advocacy navigation has to be better. Or there has to be 5% less members disruption. There's also another criteria is that if a lower scoring proposal is proposed by a statewide winner, which in this case potentially could be MOTA, then they could be selected. So if MOTA was below another proposal, but within 2.5 points, you could use that exception criteria to jump them up. Or they're also selected as a winner in a different region. So essentially you would be able to get efficiencies of scale and add those regional plans in more than one region. So that potentially could be confusing, except I think based on the proposals we had, it makes it a little bit. So as we move on to the next slide. The finalist interviews are shown here. So there were just 2 regional bidders. There was 3 variants of it because MODA proposed one combined with their own OPDP, med and RX combined, as well as a med only. Kaiser provided only one option, which was the med and RX combined option. So there is no Kaiser med only option to combine with Capital RX. But you can see in the finalist interviews here on the medical portion of it, MODA scored 71.2%, Kaiser scored 82%. And then when we talked had the interviews for the RX portion of it, MODA scored 71.6% for the OPDP version of the CCM, and then Kaiser scored 84%. So the total RX points and total medical points you can see there to the right. They do have the written portion built in. You can see the breakouts in the appendix when we get there or when we get to slides. But essentially the 12 points out of 80 are added, or 20 for the RX are added there to the right. And so as we combine these on the next slide.
And Emery, just
yes.
to make sure, these ones actually aren't analogous to Providence statewide, right?
Oh, that's the typo.
I just wanted to.
To see if anyone's paying attention.
Okay.
Yeah, no, that's I don't know why that's said. Yeah, it should be the CCM or the MODA and
You'll
Providence
fix
choice.
it.
Yeah, we'll fix it. We'll get it done. Yeah. Anyway, so if we go to the next slide, and we might have the same issue on the no, we have the right. We have it. I don't know why that wasn't there.
Just one slide.
Yeah, just that one slide. Okay, yeah, so it's in that one. Listed choice MODA and Kaiser point. Anyway, okay, so what we did was we broke out various regions. Kaiser only provided for essentially Portland Metro and I-5, right? That's where the service locations are. So what we ended up doing was talking about those locations later. And this version, MODA was the only proposer. They had 2 versions, but they were the only proposer in the coast, Southern Oregon, Eastern Oregon, Central Oregon area. So basically the rest of the states. As you can see here, the top scorer is the MODA CCM med only with the capital RX only version. Adding the medical and RX points, you end up at 75.3 compared to 74.2 with the MODA combined. Again, the criteria in this case is just different, right? In terms of disruption, advocacy, that's not being met here. We felt, like there were 2 options, one with the RX only version scored higher. And so that would be the proposal that would be available to PEBB board to select for the non-I-5 and Willamette Valley regions.
Everywhere except Portland Metro and Willamette Valley.
Yeah. The next slide shows the Portland area and the Willamette Valley area. In this case, you can see the points for the MODA up there at the top. Kaiser's the 3rd scoring points, but also is available because potentially if PEBB board deems that there's enough membership, then you can actually have more than one winner in a region. So in this case, MODA with the capital RX is number 1, Kaiser's number 3, but you can select the 2 options in this case, potentially, if you choose to do so.
Yes, I just want to reiterate for everybody online and those that are on the board, those of us that went through this whole process, understand for us, it's something that we've been doing for months. And I want to give you guys the opportunity, the other board members, the opportunity to make sure that you ask those questions because all of this really makes sense to us. And I know that this is the first time you're seeing it. And I just want to bring to light that you guys, you know, if you have any questions, please bring them up at this point. Thank you.
A couple of notes, Emery. So, and maybe you're going to get to this, but just to note that the Kaiser proposal did include both traditional HMO and deductible plan offerings. And the other thing, oh, go ahead.
No, I said thank you. That is correct. Thank
Yeah.
you for remembering that.
And just in terms of sequencing, when we get to the board action, the way it plays out is, you know, again, the MODA CCM with capital RX is the highest scored and ranked regional proposal in these two regions. The exception criteria to be able to skip over that and reach down to the other MODA CCM proposal aren't met. So, you know, as a consequence, that MODA CCM with capital RX is going to be, you know, the one that is selected for these regions. If the board does want to offer an additional regional plan in these areas, it can offer Kaiser, because once it selects the MODA CCM with capital RX, the other MODA proposals essentially eliminated from consideration, because it's basically different iterations of the same medical proposal. So then if the board feels that it wants an additional plan in that region, it can then reach down and select Kaiser.
So those are mutually exclusive, the two MODA
Yes,
proposals. It would be one or the other, but not both.
yes, sir.
And that's true for each of the sections.
Yes.
Correct. There are hypotheticals resulting from negotiation that could come into play where that MODA CCM combined medical RX proposal, you know, could be considered by the board if negotiations on the other MODA proposal with capital RX don't meet our needs. But we'll get to that a little later. In terms of selecting winners, these would be the options.
And it's an option whether we want multiple regional plans or not.
Yeah, for this particular region, I think the real substantive decision for the board to make is, does it only want one regional plan in these two areas, or do we believe that we have enough members in the I-5 corridor and metro region to support two additional or two total regional plans? And again, those would sit alongside the statewide PPO plan you select.
Thank you.
Yeah, and so, I mean, Kaiser cannot be selected ahead of the MODA CCM option, but you can select both, essentially.
Correct.
Okay. Any other questions?
Just clarifying, and Kaiser's both plans that we are.
Yes. Yeah, they,
Which I know you said already, but mode is just one.
MODA's just, yeah,
For the region, I mean, there's a statewide, but for the region.
yeah. For the regional plans, it's essentially, yeah, just the MODA CCM plan option. I mean, if you want to get technical, and because I'm an actuary, we'll take it with me. There is the full-time and the part-time plan.
Oh.
Yes. So I guess you could say Kaiser actually has four options there. You know.
Question withdrawn.
Okay, all right, just want to make sure.
When he started to wiggle, we should have known.
Yeah, I know, when I had a smirk on my face, yeah, something else is coming. Okay, all right, next slide, please. Okay, so the next few slides kind of talk about the financial proposals. And these are based on claims through 2025. Looking at prelim claims for 26, we can't really price up. I mean, the Providence collective choice issue doesn't really give us a good idea of those costs. The MODA claims look like they're actually coming down a little bit. So we might have slightly different numbers in May, just warning you. But based on what we have as of right now, the MODA statewide plan with capital RX would have a rate, as you can see here, for 2027 of 1,062. That for an employee only. That compares to 1,035 for the PEBB statewide. That's a 2.6% increase. So this includes admin fees as proposed. It includes adjustments for medical and pharmacy costs based on what they offered in terms of network. And so for MODA, it's like the Nexus network difference compared to what Providence has, as well as the RX guarantees in terms of pricing and rebates. And so right now, yeah, it's a 2.6% increase if the board elects to have the MODA plus Capital RX option to vote them in. It does assume that everybody in the current statewide plan move into the MODA statewide plan, which may not happen, but probably a substantial number would. Okay, next slide. And just to be pedantic, this is only the full-time rates. Okay, next. So the MODA CCM rates for the regional are listed here. We have the 27 rates based on essentially those, and again, the admin fees, the BAFO results. And this does assume that all Providence Choice members switch into the MODA CCM plan, and the MODA CCM members remain in there. We do not assume any switching between Kaiser and this MODA CCM plan. And you can see that the rates compared to those with the buy down is about 9.8% higher. That is a reduction from what we would say it would be the status quo MODA rates. As I mentioned, the claims for MODA have come in a little bit better in the first quarter, so these rates might go down a little bit further. But to the far right there, I think that's kind of like a point that we just want to bring up and make sure that the board understands right now, based on the option, the RFP that they provided for MODA CCM, the difference to statewide is 3.6%. The differential, in order to have a low cost plan differential, is 5%. It got changed from 10%, so now 5%, but that still does not quite meet that threshold yet of being a low cost plan. So while this does save money, it's not at the point where you have that differential to meet that 5%. So we'll talk about options in the May board meeting. We'll also potentially talk about things that we might want to negotiate as part of the RFP to increase that differential to meet that low cost plan threshold. But just wanted to bring up, based on what we currently have, it doesn't quite meet there.
And then just a finer point on that. I mean, just when we're thinking about it, and a lot of the conversations we've had at the board is the importance of the managed care, coordinated care. And there's an incentive built in that if people are choosing a plan that is more managed care, they're getting the 1%. They're choosing the MODA versus the statewide, or not right now, the Providence. And this is for state workers, not for higher ed, because I know the contract language is a little different. But I just want to say that because I know that that was the genesis of that language. It was like, how do we make sure that folks are choosing a plan that is going to be a plan that incentivizes?
Yes.
And that should potentially be a lower cost plan. It's lower cost, but it's not at this point. The difference isn't a 5%.
Yeah. So I mean, you're speaking to the intent of it, which is very important, right? It is, you're trying to set people into plans that manage better. But,
right. That's right. And I think it's just a challenge too, because I mean, the concern would be if someone's going to pay 5% for a statewide plan versus a managed plan, and that's their premium share, they might just
move into the statewide plan.
Might drive more people to the statewide plan.
So I think this is one of the crux of the matters of the day, So when we get to the negotiation portion of the meeting where we're like, what should the board ask staff to negotiate? I think we should drill down on this for Finn. Maybe let's put a pen in it, but it's like being absolutely sure we come back to it, because it's definitely one of the things. What Siobhan's saying is actually quite crux of the matter.
Yeah. Just to make sure I'm on the right track, the language that we're using of statewide means PPO. It means not managed care, and it means as a patient, I pick where I go, I see who I want. I don't have to consider quality or whatever.
So that's the crux of that's the discussion. So we gotta drill into that in a few minutes when we get like technically sort of, yes. And is that exactly what we're getting? Question mark. So that is the point of the discussion. Emery,
Yeah.
would you clean that up?
It is, I think, I just wanted to kind of maybe clarify a little bit here. So you're talking about this, Don, you're talking about the statewide PPO, where it's kind of like you have this wide network, you can go to who you want. And what is the difference between that and the MODIS CCM plan that's being offered as part of the RFP in order to get more managed care? I think part of the issue is you weren't part of the interview section, you weren't part of the looking at the questions. The offerings for the MODIS CCM plan, it's a different network than what you currently have. It's a wider network, it's the same network as the PPO network. And
That's
so,
the tricky part. So we're gonna need to drill down this in a few minutes.
Okay.
Because exactly Siobhan's point, right, which is that there was purpose for the 1% versus 5%. Yeah, exactly. And now, based on what we're looking at, there may not be as much difference as it was. And so does that split now make sense? Are we gonna accidentally drive people to the 5% plan because it's like, you know, the same, or, you know, like there's no one's anyway.
Narrow network as an incentive of behavior one way or another.
Like the presumption being a slightly more narrow network being more highly managed.
Yeah.
But what MODA is essentially proposing statewide is a pretty managed plan anyway. So like, what's the difference? And so like, why do we have the different 1% versus 5%? Why would someone choose the 1% ever choose the 5% versus it's the same network, right?
Okay.
So we need to understand that, the implications of that, and we need to figure out like, what are we trying to accomplish with the 1%, 5% thing? How is that going to be represented? But yeah, that little difference there that used to be true, where PPO, like, just kind of go, you're your own doctor, you know, like you go to whichever doctor you think you need to go to that day. That's no longer exactly the thing, right? It's all kind of a managed thing. I don't know if that was ever purely the case with, you know, Providence statewide, because they actually did have quite a bit of the management, but regardless, now very gray area. So let's talk about it, I guess, at one point when we get to that slide, you know. It's the question of the day. So let's get to it later.
yeah, it's a question of the day, and it's been now for a while as well. I mean, there's going to be a lot of discussion around that. So next slide, please. So these are the Kaiser rates. We have 27 rates as proposed there on the left, compared to the Kaiser rates for 26. One note, the Kaiser deductible rates do include the buy down, so they are a little bit different from what Kaiser's actual rates are. They proposed a 3.4% premium increase for both plans based on compared to what they had, but because of that buy down, it shows at 3.5%. So essentially it's a 3.4% increase. So for the traditional HMO, it is actually a more expensive plan than the statewide by 4.2%. But for Kaiser deductible, it does meet that threshold for state employees of being cheaper by at least 5% at 9.2. So that would be a low cost plan in this case. For the university workers, this would be the lowest cost plan in the regions where Kaiser is available. Otherwise, the MODIS regional plan would be outside of the metro and I-5 border.
And the way it looks right now, the only folks who would have access to the low-cost plan who work at the state would be people in the I-5 corridor. Right. No one else would have access.
We didn't before.
No, you didn't have, access to Kaiser, but you had access to a 1% plan. But, I mean, anyway, as they currently stand, there wouldn't be.
Unless, yeah, the CCM plan was bought down or.
We're talking about absolutely today and where we're going, correct, but there is room, as we're saying.
It's not a new problem. It's something we.
Yeah. Yeah.
Okay. Any other questions, comments? Okay, the next slide is the impact on the composite. So I think, right, the comparison against the 2.4%. So that the two bottom lines, the bottom two lines are the ones to focus on. The penultimate one, the status quo, 27 status quo. That's the number that showed in last week. So it's an 8.7% change, which is above the 3.4% limitation by about 76 million. The RFP does bring it down to 6.6% above, which is still above the 3.4%, but did reduce the deficit by about $29 million. Again, as I said, the motor plan claims are coming in a little bit lower, so maybe that's actually going to be, the delta is going to be a little bit less. Well, the delta to the 3.4 is going to be 3.4% is going to be a little bit less. Right now, based on the RFP, you're about 45 million above that threshold, which is a little bit more manageable than 75 million. But if it comes down a little bit more, it's going to be a little bit better. But still, those are the types of considerations that we're going to have over the next couple of board meetings. But yeah, there are savings. It unfortunately doesn't get you to 3.4%. Okay. Is this still my section, Brian, or did you want to?
No, you guys have it to the very last section where we talk about next steps.
Okay. Selecting winning proposals. Okay. So selecting a statewide winner. And actually, we have text on the next slide, don't we? But this is just kind of like a reiteration of the statewide rankings. Right now, Moda statewide with Capital RX is the top ranked at 75.6 points compared to the other options. Let's move to the next slide, please. Okay, so board action is requested here. So it is the recommendation of the RFP staff and Mercer that board selects Moda and Capital RX as statewide winner, given that that's the option that's available to the PEBB board, and we feel like the RFP, did provide savings, and so we want to move forward in this case. So there are some notes there on other considerations that we want. Are asking the board to direct Mercer and staff to negotiate in order to sign that contract with in this case with Capital RX and Moda. So there are a couple bullets there at the top. With Capital RX financial guarantees that essentially ensure that the savings that were proposed actually end up being observed, as well as trend guarantees that were mentioned in, I think, the finalist interviews. And then the second one is just discussions around the formulary about the potential changes that might be allowed without jeopardizing the guarantees that they provided in the RFP. So it's just negotiations around that, discussions around that, and potential contract clauses to ensure that the PEBB board has the options. Yeah, I just saw that. Andy?
So I just wanted to, again, and maybe it's further up. I would like some type of guarantee on the minimal disruption of members from Providence over to Moda, and that they have the staff and a plan to do that. That's just one of my big concerns. And also, just FYI, I know that the universities are concerned about not having a low-cost plan.
Yes. Yeah, so definitely on the low-cost plan, and as well as, discussions, guarantees around the implementation and, just like taking over of like all the membership from Providence, because we are talking, 80,000 members, right? And not having that continuation, or it's not really continuation, but the similar instance of what's currently happening with the Providence Choice Collective Health. But yes, that's part of it. The implementation is definitely going to be a big part of the contracting and other terms in this case. Some other considerations to negotiate with MODA are the final 3 bullets. Just kind of talking about plan design, rates, financials, network changes, making sure it looks like a PPO, and I think the second part's really a little bit more important. It's more adequately differentiated from the regional proposals. Again, that 5% and demonstrating that really more like the CCM plan, the coordinated care plans are managing care better, or, I don't know if this, we want to manage care as well as we can for both plans, but, just really differentiating and providing that value for that differential in the contributions. And then that also ties into that, the bullet right below in terms of cost differentiation, so that the 5% threshold ends up being met. And so that 1% threshold is, the 1% contribution is there for state employees. And then this other one, it's like talking about, like with MODA, about options tied to making sure that the 3.4% increases are being met. And that's not just in 1 year, but it's in multiple years. It's medical costs are going up. MODA is potentially gaining a lot of membership, and in terms of the size, especially with OWEB, there's a real need to meet that 3.4%. And so in talking and ensuring that there are things being done to keep trends lower, cost increases lower, and so that there don't have to be plan design changes. Like, what can we do to make sure that we have 3.4% or get close to it long term?
So Emery, so these are the things, I think, the MODA items that Sean was alluding to that may require just a little more discussion. I'm thinking we probably want to pause for discussion, but before we do, there's actually 2 slides of recommendations for statewide. So maybe let's preview the next slide, but then we'll come back to this and then open it up for discussion, if folks are okay with that.
Okay. Good. All right, let's move to the next slide. Okay, thanks. So part of that board action, I think, I guess it's implied, working with board leadership to assist in setting negotiating parameters and the steps that are needed to get to an agreement, as well as, whether we need to go back to the full board to get direction if we feel that things are not progressing the way they should, and what should we do next in this case. So in this case, I guess some examples here, for example, some areas that aren't acceptable in terms of negotiations. And then if that does arise and we are reaching essentially an impasse, potentially, we could discuss beginning negotiations with the next statewide proposal in this case. But, that's just in case it happens. It's not, we would do that, but it's just like we're asking that the board allows, us to determine whether, we are reaching a point, and then to bring that back to the full board to potentially negotiate further.
Yeah, and this allows PEBB staff and Mercer to move really kind of nimbly if we do hit an impasse, or if there are major issues we encounter during negotiations. Being able to work with board leadership to quickly determine next steps, rather than having to wait to the next scheduled board meeting or schedule special board meetings along the way, just makes it a little more efficient. Ultimately, we're not going to be finalizing anything without coming back to the board, as we'll get to later on, and asking the board to approve the final plan designs and rates.
Hence the restrictions on the talking point.
What's that?
I said hence the restrictions on the talking points that.
Correct. Correct. I mean, until the board approves the plan designs and rates and the contracts are at least substantively negotiated, other proposals could be in play. So we continue to keep the communications locked down because the process, is still formally ongoing.
And that medical RX proposal, that would be the backup is OPDP, medical OPDP, because that's MODIS.
Yes.
It would be. I mean, it's a little awkward in this situation, because if we hit an impasse on the medical side with MODA, it doesn't necessarily make sense to go to the next iteration of a MODA, contract if the same issues are going to persist. If the issues are with Capital RX and we had an impasse, then it would make sense to go to the MODA combined medical pharmacy statewide proposal. But it's really on a case by case basis, which is why again it's more efficient for us to work directly with board leadership along the way, rather than having to come back to the full board in every instance where this may occur.
So, just kind of move us along here. I was thinking that, I could make a motion and then we can discuss it.
Yep.
For a bit, right?
Yeah, we're definitely at that
So
point.
let's go to the previous slide. And Sean, was there something you wanted to discuss first? Or are you thinking motion and then you want to discuss one or more aspects of these negotiated items?
Why you can make a motion, then you discuss it, or you can just
You can
discuss
skip
it.
to your motion
So-
after the session.
Right. But here, let me just cut to the chase what I'm after. So like, I think these are all, so I'm thinking to make the motion of accepting the recommendations on the screen, and then I have a couple of add-ons, right? So first of all, on the bullet point related to creating enough cost differentiation, right? There needs to be enough cost differentiation, and there's a flip side to this decision that's in the regionals, right? Which is the opposite of that. But nevertheless, we got to do things one at a time. And so this is what we were starting to get into. Siobhan brought it up, right? And so I just kind of want to lay out a couple of like values to bring into the negotiation, but it doesn't substantially change the bullet point. Does that make sense? The way it's worded. I just want to add some detail. So, and we've already basically said that, so I'm starting to restate some things. So healthcare over time is getting more expensive. We understand that. So, at one point in our reality, it was like, you have a PPO version and you just kind of go wherever you want. I had one member who just like told me the reason why they took the statewide every time is because they had a doctor in California that they really loved, and to do this one thing. And they would go every year, they would fly down, see their sister and whatever in LA, and they would have this doctor. Okay, so that's probably, it's a new time, but the point is that there is a difference between a statewide plan and a regional plan. And there's a health and cost purpose to that. And one of them is that we actually think that the regional plans, the lower cost plans in each region are lower cost because they are doing something that is more planful around managing people's health, right? And that might require a stricter, network, or it might require a like centers of excellence or whatever it is. It's not just that the plans have different benefits and this one's $20 and this one's 40, it's not just that. There's more purpose to it. And so I'm just saying, like, bring that to discussion, right? We're trying to find something. There needs to be a plan that's 5% more than the other, but it's not just that's the problem. You're like, oh, that's easy. We'll just make this more expensive. That doesn't solve anything, right? So that's the point. Okay, so that's what I'm asking you to take into that room. Now, having said that, the other thing that I would like to see is that I didn't see from MODA a long-term strategy about containing 3.4%, other than some of the things that we already have in play, right? So what I would like to see is a 5-year plan that has a strategy that they are approaching on a strategic level to actually contain costs long-term. And I want to see what that plan is and negotiate it together. I'm not, and that the contract would have the abilities that every 5 years that there's an opportunity to revisit this plan. It's a strategic plan that brings in some creativity and just like, we're going to do things differently. And so I would like to see what that is, just that there's some thought going into it, right?
And Sean, is there any reason why we wouldn't want to ask that of every ASP or winner that's selected today?
Well, that's something, not just for statewide. I was gonna wait till you were done, but I think that's something we should do for everyone
We
because.
should do that for all of us. Just stick with it.
Perfect.
You're on this slide, which is the slide we should.
Yeah. So that is going to be a recommendation. I've been a review.
Oh, I know. You're doing great. Keep going.
So there's that, and then otherwise, what we have here, the financial guarantees, strategies to limit increase 2.4%, creating this differential, and then to Andy's point, this is something also that's not on the slide that I'm adding, is that we do need to have some clear change management plan, whether those are in terms of guarantees or assurances or this and that, but there will be a big change. We're already getting a bunch of incoming from our members with a whole bunch of worried people who have very fragile children or whatever it is, right? They have family members and we're gonna need to be moving them at least on insurance, right? And we need to be sure that we don't skip a beat, right? That there is a plan for that. And related to that same point, this is a lot of new people that is going to be coming over. And so we need to have the discussion about, are they ready for that? Are they going to be ready for that? What does it mean to be ready for that? Like, what are they anticipating? What are they not anticipating? And that's an active discussion. And then that's part of the assurances in the contract, right? Which is that we're ready for that. We have plans for that. We're gonna try to, if we have gaps in Portland, let's say, of Providence's network that's currently not on MODA's, that we're gonna work on getting those onto the network between now and the beginning of and so on, right? So in other words, just the plan for transition that includes, high case management transition, volume of transfers, and also network disruption management, as far as trying to get gaps of provider networks from Providence onto the network. They're still providing healthcare. They're just not doing the healthcare plan, right? So presumably they're still in business. So, if there aren't contracts in place, then we need to be working on getting them in place. And so anyway, that would be the transition plan, is what I would put all that underneath, that we would want to see that in what's the plan?
And to add to that, Sean, I think one of the things you're also saying is what we've seen right now is when collective health took over, a lot of those individuals that have those specialty drugs or those places where they go that are kind of in network, but yet have been, what they call them, the referral type stuff, that we make sure that those people are not disenfranchised and lost in this transfer, that it's going to take you 6 more months to get that referral redone for something that's going on. If you have a referral now, maybe there's a 90-day window where it continues, and then they look at it as it continues, not cut you off and then look at it, something to that effect.
Yeah. Yeah.
Because that disruption, like we said, is gonna, we've already seen that and dealt with it. We don't want to deal with it again next year.
Yeah, so I think our members and the board and staff
Yes.
are already just kind of like gun shy of, right? Because we just went through this thing where it wasn't planful. And that's not Moda's fault. I'm just saying,
Yeah.
that's just what we're dealing with. And so we just kind of have to be like, careful about the transition is all.
Yeah.
And I just want to add on, I want to do a yes and on that, just around the prescription drugs, because if there's a change that is going to be everyone in MODA moving from OPDP to capital RX. And I mean, we need a change management plan around prescription drugs. Well, so not just.
Yeah.
Yeah, I can't believe I didn't bring, yeah, thanks. So, right, so we need to understand in the negotiation process, what does the cooperation plan look like between the two, right? And we need to be satisfied with that cooperation, because there is an intention to have coordinated care between pharmacy and medical. And if that starts breaking, because one of the two partners isn't either fully committed or fully, anticipating this and that, then that will be a failure. And so, yeah, thanks for mentioning that. So that feels like a separate bullet point. That there is a plan on both sides that the board feels good about how they're gonna manage that new relationship.
Took down the notes. Unfortunately, I think we have lessons learned from Collective Health Providence that really helps.
Yes.
Highlight the issues.
It's free education here because what a nightmare. And it's not over. I don't know, there's no past tense to any of this. It's alive and well.
Yeah, so we can definitely work with or have staff, really collect all of those specific things, because I think they, those elements you're bringing up, right? It's like, we don't want those to happen again. So what has happened, we can definitely collect that and work on making sure there's a plan for this.
So what is that, 3 extra bullet points?
Yeah, I don't know. Yes, we definitely have some of the stuff that's not necessarily written on this slide that we've added, but yes. So we can add that as a bullet point. It's really the
I'm trying to get to it.
yeah, the care management implementation plan and other like care related network and other changes.
So do you want me to try to recap them? Would that be helpful?
Yeah, that'd be great. If you can like word some kind of motion that I can be like that.
Well, I was going to recap the additional points. So in addition to the motion or the recommendation as written, Sean's proposing a few other key considerations. So one, when we're talking about negotiating plan designs and rates, in regards to the PPO versus regional plans, we need to focus on the intent of the plan design and type of plan and not just on getting to 5% difference.
Yeah.
Okay, number 2, 5-year plan from each of the selected winners to manage to 3.4% annually. It should include strategies. And as an add-on, I think this came up before when we maybe during one of the finalist interview debriefs, but in addition to managing it annually, it should include things that are actually actionable and wouldn't require necessarily like changes in law that have obstacles that currently prevent us from even doing them.
Yes.
So that'd be number 2.
Yeah.
Number 3 would be very strong performance guarantees with corresponding penalties and or fees at risk for implementation and member experiences related to implementation related to these selections made today.
Yeah.
And kind of related, but it's separate. We need plans from each of the winners for member transition and how the various coordination will happen. And this is in particular for knowing that folks currently enrolled in Providence will be enrolling into either a MODA or Kaiser plan. And those who get their pharmacy benefits through OPDP will be transitioned to Capital RX.
Yes.
All right.
Yeah, let's do it.
So before we go down that path, I know we're headed. The one question that I had from the prior sections that I didn't get to the point of being able to articulate was about the OPDP as the existing partner of MODA and the 1% and 2.5% within which they needed to fall. Have all of the avenues been exhausted for considering any of the options for including other plans? I think they were exhausted as we came through. We're like, this is how it came out, and here are the ways that it might have gone a different way, including OPDP as a standalone prescription plan that could have been combined with the medical and including the MedRx combined. All of those avenues were exhausted and we came to the singular options that we're about to propose.
Correct. But based on all the RFP weightings, how the different processes were established, how things, proposals are ranked, selected, et cetera, we highlighted the only viable options that were available to you under the RFP. And again, part of that is, part of Providence withdrawing means there are quite a bit fewer options and iterations and permutations for you to consider.
So that is the thing that is making me most uncomfortable right now, having as few one option as we have. And before we go down that path, I would like to understand what our actual options are. What's our platform for negotiation? What are our options if the negotiation doesn't go in a way that facilitates meeting our stated goals?
If we hit a negotiation impasse, there could be various options depending on if it's a true impasse that the board can't accept or get past. Ultimately, the board can choose to withdraw the RFP, withdraw selections, withdraw the RFP, and try to work through all these various issues in the context of negotiated renewals. I'm not so sure that situation gives you any benefits or puts you in a better position than you are today. There are probably even more extreme options that we would need to work through as a staff, such as if we hit a negotiation impasse with one or more selected winners, and with Providence, abruptly withdrawing from the market, do we have the authority to just pursue a contract with directly with any carriers in the marketplace? Again, I don't even know if we would have the legal authority to do that, but that'd be an option we would look at. So there's not a whole lot of viable options in front of the board for 2027, unfortunately.
Okay. And
We
this,
do have some slides at the end, and we don't need to go to them now, but I can just kind of preview them where after we anticipate making selections today, we basically ask the question, given the fewer options available than what we anticipated, is this really what the board envisioned or was hoping for? And if not, I think there are some ideas and strategies that PEBB staff and Mercer can develop to bring back to the board, perhaps like at the fall retreat, for other options to adding plans in the future. I'm not aware that any of them would be short term. I think, again, they may involve like more focused procurements. Maybe we want to go out for an RFP for a specific region or a specific type of plan. But even those, take a little bit time to develop. So all that is to say, even though the board doesn't have a lot of options for 2027 in front of it now, I think there are things we can look at to give the board flexibility to potentially add plans in the future.
So this is for 2027.
Yes.
Okay, thank you.
That does bring up one more bullet point though, I forgot. Which is, we also need to understand the disruption plan and transition plan and what have you for, out of state employees.
Mm-hmm.
So just like, what is that network? How many of our people would be disrupted? What is the plan for managing that disruption, et cetera?
That population.
Perfect.
That is, yeah, it's a growing, yeah. And so we need some kind of plan around our out-of-state employees, and I don't mean plan like, but it's just that that's a growing group. And so, basically throwing an ad hoc contract at whoever it is that they go to, that's not really a plan. That's just kind of, pretending like we're mostly an in-state thing. I mean, we are mostly, but I'm just saying it's growing. So we kind of need a strategy. That was the word I was looking for.
So we can do that. We can add that to your fourth item, when we request plan for member transition, we can ask them to specifically call out and to describe separately, how this is going to work for out-of-state employees and their dependents.
And I would add that also as a subpoint to the 5-year strategy document, because that may be part of the 5-year strategy, depending on how much, cost containment we're losing there. I don't know. So at least worth looking at.
Rep. Nels?
I'm curious, can the scoring committee or the consultant offer some insight as to why we've only got, I know Providence pulled out, but like why didn't anything else rise to the ability to meet our needs for the statewide plan? Can you share anything?
So I can speak a little bit about the fact that I think we had 2 or more proposals that we had to reject because the proposers wouldn't agree to certain state legal terms that are non-negotiable, that were advised by DOJ.
Such as?
Off the top of my head, I can't recall which legal provisions, but they were kind of the handful of critical ones that we don't allow any deviation from. So one of the requirements was they had to accept our non-negotiable terms that the state lays out. And again, we didn't include all of our legal terms and conditions as non-negotiable. We worked with DOJ to identify those specific ones that were really critical. So, and in some cases, if I remember correctly, the proposers were unwilling to agree to multiple non-negotiable items. In terms of the second part, though, I think there were proposals that we feel just didn't perform well enough to be invited to finalist interviews, based on how all the RFP was set up with the scoring and weighting and priority areas. So I think between those two things and then Providence withdrawing, we were left in fewer options than what we would typically expect of this kind of size of an RFP.
Okay, that was I hate to say that, I'm not trying to be critical, but that was a sufficiently vague answer.
Yeah, what specifics are you looking for? And granted, some of them, or a lot of them, we may not know off the top of our head, and some of them, depending on what level of information, may be difficult to share in a public
I understand.
setting.
All right. I mean, I don't want to redo the work of the committee, so I might just leave it at that.
We did provide, I think in the prior presentation, some areas where some plans scored better than others. I do think, based on reading the results here and some other work I've done, Oregon has pushed the health plans to do more than I think other states, other locations, other clients have, especially in the areas of behavioral health and like health equity and those elements, which are very important to PEBB in Oregon. And it showed, I think, in responses, and showed in the programs, and shows in the stuff that was that the bidders had, could demonstrate in terms of what they accomplished and what they were willing to do. And as a result, I think some of the others did not, some of the, I guess, newcomers, let's just say, did not score as well. And the incumbents seem to score much, much better in those because they have been doing it. And it is something I've seen in a different RFP where it's like, those elements score better for like a bidder. So it's kind of like because they have been pushed and they are doing those things. So I think it's kind of like what's important to PEBB, what's important to Oregon, and just the scores and the responses showed up this way, where there was a pretty clear differential. Does that help?
Yeah, I mean,
A little bit.
yeah, I mean, Rob, what you're saying, what Emery's saying is kind of the score, right? Like we are not easy on our plans, right? Like we push them all the time to do various like innovations and things.
I understand that, but then
Well, what I'm saying is when it came to some of the nationals applying, they were not competitive.
okay. I mean, I'm not. That's fine.
That is a limiter. I mean, how much is that being asked? It is a limiter. It is something I think Brian, I mean, we've discussed this internally, right? It's like, what do we do? Because we are asking so much. What's the
Well, yeah, and I had mentioned, we have some slides at the end that are going to kind of ask the question, is this really what we envisioned? Right. And I think most of us can agree, like we thought there would be more meaningful choices to make at the end of the process, but there aren't. So one of the things that, again, the board can ask PEB staff and Mercer to do, in addition to thinking of additional strategies, is, help facilitate a discussion at the retreat about, are we asking too much? I mean, if we want more choices, are there areas where we need to relent a little bit? And that's not only on the board decisions, but Representative Noce, that also includes like staff is going to have to go back and fight some battles potentially with DAS and with DOJ to really push like, hey, here are some items that have essentially gotten folks rejected in the past. We want at least to be able to consider them and get them to the starting line. What movement do we have? So I think all these are discussions that we need to have going forward, even after the board makes decisions today.
This is Klauser. I also think, and I'll get to you, Rep. Noce, in 1 second. I think one of the things we need to remember too is that, Providence and MODA have been with us for many years, and they're still, each time we do a renewal, they're having, to really, really push hard to get to that 3.4. And to bring someone in from outside that's never done 3.4, they're doing 9, 9.5, 10 every time they do a renewal, and ask them to do that. It's really hard for them to commit for the next 5, 10 years if they're going to do that with us.
Yeah,
It's a hard thing to do.
some of them didn't even mention the 3.4.
Yeah, and some of them didn't even, they didn't even mention they would even be close to 3.4.
Maybe they didn't think that we were serious or whatever.
Yeah. But go ahead, Rep. Noce.
Well, I guess then I can't tell I'm going to feel like I'm talking out of both sides of my mouth. Like at one level, I feel like we're bemoaning that we don't have more options for the statewide. And I have to confess, I'm a smidge confused about what we're doing with the regional. So I hope we get to that next. And then another level, we have a local carrier that is willing to do it and commit. And so I'm like, okay, like that's what the process yielded. We've got someone that can do it. I'm not hearing I don't think I'm hearing deep objection. I think I'm just hearing like, well, it's a little weird that we only have one choice. Well, that's how it worked.
Right.
That's how the score.
That's how it turned out. We didn't expect, like Brian's saying, we didn't expect it to be there. but this is where we are, and
And I think that
I guess,
so,
I guess maybe, given what you've all just sort of opined about, I guess I'm not surprised. Like,
Yeah.
we've
It
had
is.
yeah, I don't want to opine about 3.4% too much right now.
Yeah.
It's probably not a good idea.
Yeah, it is the world that we're currently living in, and we just have to.
It's a tough world right now.
I think Andy, you had it.
have Andrea and then Dawn.
Yes, I think, so I share your frustration, Rep. Knows, and that's, after being on the evaluation committee, I think it's hard because honestly, I don't feel there's a good option. We do not have, in my opinion, a good option. I don't like having only one plan, just because I worry that people don't have a good choice. And I'm very, very worried about the transition for 80,000 people. But again, we didn't have that much. And so I am putting my faith in Mercer and our team to come up with some other options as we move forward, even if after we vote on all of this.
Okay. I mean, again, I don't want to, I opted out of this, and I don't want to redo the work that everybody else has done. This is hard. But like, I don't see how you're going to get other options.
Well, I think the disruption analysis will tell us a lot. I think one of the carriers dropping out implies a loss of great, access to providers around the state. And I don't think that's necessarily true. I mean, I think there's a lot of work to be.
I mean, hopefully MOTA will, I mean, Providence still wants to be a provider. They just don't want to be an insurance plan. Hopefully they'll want to contract with MOTA and get our business. I can't imagine that they don't want to.
Dawn.
Okay, so three things. One is the contrast between 3.4% and the costs of healthcare generally are one of the challenges to what we're trying to achieve. And that keeps getting more intense over time as the 3.4 stays steady and the cost of healthcare, that curve keeps climbing. So that's one. Two is, this is our job. Our job is to push as hard as we can push and get as much value for our members as the market will bear, as it will tolerate. And until Providence dropped out, we had some decent conversations going on about that. And maybe we found it. Maybe we found as far as the market will bear, at least in this moment, new entrants to the market notwithstanding, right? Maybe there's still some more capacity there that they will figure out and whatever. But so we are doing that part, and I think it's a good thing for us to do, even though at some points we find ourselves in a place where we may have to re-examine what we think we can get out of that negotiation. And number three, I would like to make a motion.
Thank you.
Is there another comment before that? Or
So
are we
at this point, do we have a motion on the floor?
We don't. Okay.
I just wanted to make sure.
Yeah.
Okay.
This is good.
I know Brian had said this is what was in the motion. I just wanted to make sure. So go ahead, Dawn.
I would like to make a motion that we proceed with the recommendation and the additions as suggested and documented.
Okay, so we have a motion on the floor. Do we have a second? So I have a motion from Dawn, a second from Siobhan. We've had quite a bit of discussion. Is there any more discussion on the motion as presented? And Dawn, I would add that is with your motion is with the additional pieces that have been put forward and added to these bulletins, correct?
Mhm.
Okay.
And it's for only the statewide.
Yes, we're just doing statewide at this time. Okay, seeing no more questions, no hands? No, okay. I'll just do, at this point, all in favor from the board, say aye. Any opposed?
Aye.
Yeah, I gotta wait. Any opposed? Any abstentions? Okay, so that motion passed. Thank you.
Okay. So the agenda actually has a break. Do we want to take a break? Or do we want to continue on to the regionals?
Probably a good idea.
Yeah, let's
I
take
was
five.
worried, that's why I ran.
What's the break? I didn't get the.
Oh, there was like some 5 or 10 minute in the agenda.
Let's do like five and everybody just
Five?
file back in.
Okay, all right.
We're taking the break. I'll see you back at, I'm gonna try to, I'm gonna try to quickly go get an espresso and come back.
Oh, yeah, one. Thank you, sir.
Okay.
There isn't a place to do that in this building, is there? An
I
espresso?
think they have the shop might have it.
What? Oh, whoa, I'm going.
Hey, guys, you should mute the room when you're in break.
Coffee time.
Can you go on mute,
5 minutes
please?
worth of coffee.
Yeah.
You guys, everything's being picked up.
It does.
Okay.
Is it unmuted?
I think we're unmuted, right?
Is it unmuted? Hello, everybody okay? Yes, it is blue up there. Okay, I believe we have everybody back in the room. If you are online and want to put your camera on, that's fine. We will move on to regional at this time, and I'll turn it back over to Mercer.
All right. Thank you, Chair. The next section, selecting the regional winners, will be very similar to statewide in terms of process. There may not be as much discussion, but we'll see. But we're going to go through two different regions. So we broke it into are essentially the non, it's, as you can see here, the coast, southern, eastern, and central Oregons. So basically the non-I-5 corridor / Portland metro area. And then we'll go through and do the Portland metro area. The reason we're doing this is because of where the bidders proposed that were the finalists. MODA did propose across the entire state, but again, Kaiser only proposed essentially in their service areas, which is the metro area and I-5. So focusing on essentially those other portions of the state. We do have the rankings there listed. There's again one proposer, no other CCM. They did offer two options. One med only to be combined with the RX only winner, which is Capital RX, and then the MODA CCM with that's combined med RX. So you can see there on the points awarded out of 100 in combination of the medical and RX points. The MODA CCM with Capital RX is the winner. 75.3 compared to 74.2, so it's the highest score. Again, with the exception criteria, we listed them previously, but felt that none of the exceptions were met in order to bump number 2 up to number 1. And so therefore, that board has the option of voting for and accepting MODA CCM with Capital RX as this regional plan in these locations. Rep knows.
So the CCM is basically a more managed care style of benefit, correct?
That is the intent, yes.
Okay. And then is that what makes this different than the MODA statewide because it's a more managed care style of benefit?
I'm just going to use the word intent again. Yes, that's the intent. It's also historically it's only been in more regions, like more regional in that case. But it is, yeah, it's supposed to be more managed. And I think really to Siobhan's point, just ensuring that this regional plan is actually managing care, providing that value, that differentiator to provide that more managed. Yes.
Then my last question is, why would they not offer it in the metro area?
They do.
They do.
Yeah, we'll get to that section because Kaiser's also an option in those sections.
Got it. Okay, thank you.
Okay. Any other questions before we move on to the next slide? Okay, let's move on to the next slide. It's going to be very similar to what we discussed for statewide, really. There will be board action requested on these regions, and those regions again are at the top, those 4 locations. Recommends that MODA and Capital RX, and again, this is the MODA CCM, the regional plan, be the regional winner for these regions, given it's the only option, really viable option for PEBB under the RFP rules. We do have these bullets. Again, I think a lot of them are very similar to what were for statewide, but to the point, I think of, that discussion with Representative Noss and what Siobhan has brought up and others, this is like really the bigger issue is not just the contractual, the contracts with the state employees, but really what is the differentiator for a regional plan versus a statewide, and what makes it a better plan, and the reason why you want to drive members to it through the contribution differences. And those discussions, are part of what we want to have with the winner, and to demonstrate that there is additional value for that lower contribution in this case.
And Emery, I think that, the items that we added to clarify the recommendation for statewide seem to apply here. I think they would be the same items that Sean previously raised.
Yes, yes, they would be, and, I mean, they are, so if we actually go to the next slide again, just to get that information up on the board. So, next slide, please. Thanks. So again, this is very similar, but, there was a lot of discussion around statewide, right, around the items that, to negotiate, to discuss, to make sure, in terms of implementation and transition and all of those things. It's not currently on here. I think probably you would still need to make a motion regarding that. But yes, but those essentially would apply. There would be more of a focus on just, regional portion versus the statewide portion, but all of those other things in terms of integration and care management, disruption, well, I guess not that. Well, there's a little bit of out-of-state disruption, but those other things would also apply in this case. So I will leave it here for, I don't know, discussion or motion.
Yeah, I mean, I agree. I think it's the same, pretty much. Brian, do you have them there? Do you have those extra points?
I have my handwritten notes, which I think I can decipher.
Yeah, do you mind just kind of to get it back on the table,
Yeah, so there's number one, when we're talking about differentiating PPO from the CCM plans, we need to consider the plan design and plan intent, and not just focus on getting to 5% difference. Number two, 5-year strategic plans for meeting the annual 3.4%. 3, strong performance guarantees with fees at risk and or other penalties for implementation and member experience related to implementation. 4, a plan for member transition, and that's would include both for the folks going from PHP to MODA and also OPDP to Capital RX. And then also, how does the transition look for out-of-state employees? And that could be added to the previous item, and also should be addressed as part of the 5-year plan.
Yeah. So I would say, like not needing to rehash it myself personally, but I'm open to discussion, of course, but I would say that plus the, recommendation and bullet points presented by Mercer on the slides would be my motion.
We have a motion on the floor by Sean to accept what is written and the points that were discussed both from the statewide and also placed here on the table by Brian. Do we have a second?
I'll second it.
Okay, we have a second by Kimberly. And then discussion.
Point of discussion, there were more bullets on the statewide and I don't remember what they were. But if any of those. Yeah.
Can we go back to the 41, slide 41?
I think there's 2 slides.
Yeah, there are 2 slides. Emily, can you pull up one slide? One more. Thank you. Oop, too many. There. Okay. Well, 41. 41.
41.
That's it.
So those look to me like they mirror the
Yes.
statewide ones? Okay.
Yeah, they essentially mirror.
All of this applicable? All right. As long as all of the applicable considerations to the statewide question are being applied here to the regional, that resolves my question.
Any more discussion in the room or anyone online? I see no hands.
Oh, Emily.
Oh, now we have a hand. Go ahead, Emily.
Yeah, thank you. This is a lot to take in, and I really appreciate the discussion we've had to this point, and all the people who were so involved in vetting all of these proposals and that. And I'm just reflecting on the conversation we had right before break, and then I had this out of the box idea for potentially future negotiation kind of points. And maybe this is like completely outrageous and out of scope, but I'm just going to throw it in here. But you know, we have all these tribal health clinics around the state, and I know that they can often serve non-tribal members, you know, in with different caveats, whether oral health, dental, and that kind of thing. And so I just wanted to just add that from an equity perspective. Possibly that might be something to explore in the future, if needed, when we're negotiating final details. So I don't know if anyone has experience with that, working with the tribal health clinics statewide in
So
Oregon.
Emily, is your kind of question for us during negotiations to look into whether tribal health clinics are included in the proposed networks? And
Correct.
if not, just inquire about the possibility of adding them?
Yeah, that's a proposal. Thank you, Brian.
Okay.
Yeah, we can definitely do that, and talk about it. I mean, I'll have to check the data to see if, I'll check the data. I've worked with travel clinics in terms of the Medicaid program, but, we'll definitely look into it for PEB.
Okay, thank you.
Thank you for that.
Mhm.
I see no more hands. Okay, so at this point, the motion as presented, we'll take a vote here. So anyone, let's see, all those in favor, in the room, say aye.
Aye.
All those online, say aye.
Bye.
Any opposed in the room or online? And any abstentions? All right, with that, that motion passes.
Okay, thank you. The next slide gets to the I-5 corridor and metro region. So this is the rest of the state where the bulk of the population is. We have the table here with the three proposals separated out. So the MODA CCM with the capital RX, the RX only, is the highest score at 75.3. The second option, which is essentially a duplication, except it's with the OPDP, is at 74.2. The exception criteria, again, doesn't really apply. So the option to the board would be the number one option there, the CCM with the capital RX. But there's also the Kaiser Med and RX, which scored 70.0 and isn't, scored 70.0. So it's, while it's not the highest score, but there is the option of selecting multiple proposers in a region if there's essentially sufficient membership. And I think we all can probably say that 50,000 employees and like close to 100,000 members is probably sufficient to have at least another regional option in this case. So if we go to the next slide, as talked up there, there are a lot more members, right? So there's we believe that you could have at least you have the two regional winners in these regions. So board actions requested first would be to select MODA and capital RX as the regional winner, as the highest ranked proposal. And if that is voted on by the board, then there is the option for the board to vote on Kaiser Regional, which would include the traditional deductible plans as a second option in this region. I think, Brian, I don't know, or Ruby, if there's anything else you want to say about the technicalities around that.
No, I think in terms of the RFP structure, it's pretty straightforward. I don't think there's much more to spell out unless there are questions.
Okay.
My only question would be, is there another slide where we're going back to the considerations?
Yes.
Okay.
Yeah, and so in terms of that, that's like essentially our recommendation. And we also do have the considerations on the next two slides, which essentially, let's go to the next slide, please. So the top bullet, oops, no, go back one. Okay.
Yep, back one.
Back one.
45.
There we go.
Yeah, okay. All right, so again, so the top few bullets are very similar to what, you know, on the other ones. We do add the one for Kaiser there down below, which is like, you know, it's a very similar bullet around the cost differentiation and regional plans to maintain the, you know, the way that the collective bargaining agreements work out. They currently meet that, so it's not as big of a consideration. But in terms of, you know, limitations to 3.4%, or like strategies around that, I think all of that would apply. Integration might not be as big of an issue, or like implementation, but if they do get members, obviously, making sure that any transition is fine. Actually, let's go to the next slide as well. Again, this is very, very similar in terms of the items as before, just with the additional Kaiser bullet down there at the bottom. But in terms of the considerations, you know, additional bullet points that were provided in the other ones, I think those would all also apply here. So I guess yeah, go for it.
Can I just ask a question about the Kaiser piece? Because if Kaiser does pick up some folks from Providence, there would be some continuity of care, wouldn't there be, for like the alternative care, the mental health care? Because those don't always happen within the closed system. I mean, I understand that like there's less options for some pieces of it, but there's other parts of Kaiser that they contract, right?
Yeah.
Wouldn't we want to make sure we're having those same transition plans?
Yes. Yeah, that would be, those would apply. Probably fewer members, but those would still apply in this case. Brian, was there something?
I would say the same bullet points that we discussed earlier apply, or should be addressed to the extent they're applicable. So, for example, for Kaiser, I'm not so sure there'll be a need to have separate plans for out-of-state members. I'm not sure how they, you know, how that is provided into the Kaiser plan, if at all. So, but to the extent it does apply, we'll apply all of those talking points or discussion points that you raised to each and every winner.
I have different bullet points for Kaiser.
Okay.
So I would think, just for efficiency, I would just say, like, why don't we just do the MOTA thing first?
And that's what I was gonna ask, if we want to do one, then the other, or if we want to do them both as a slate.
Just for clarity, I think that makes sense. Yeah.
Although, should we just vote that we're gonna offer both plans, or just one, or just as a separate, and then move to the differentiation?
Whichever.
Anyway, like-
Yeah.
Whichever way you want to do it.
If I do 2 votes, we could just do 1 and 1.
Because I can, yeah.
Like I do 2 votes, we can just split it up. It'd probably be easier.
Yeah, I think the way that the first slide kind of said, it's like you vote for the winner and then you decide whether you want to offer a second option.
We can motion first. Okay, so I would entertain a motion to choose a I-5 metro region plan.
Yeah, so I'll move that we choose the highest scoring, the MOTA. And it's the same discussion we just did with the last regional thing. So it's the same.
Yeah.
It's the same motion, just these I-5 corridor regions, basically. So that's the motion.
So a motion on the floor by Sean to adopt the highest scoring in the I-5 corridor metro region, including all of the items in the state regions with this motion. And do I have a second? Second. Okay, we have a second by Dawn. And then this being the exact was before, do we have any discussion on this one? Seeing none in the room and no hands. We'll go ahead and then take a vote. So all in favor in the room, say aye.
Aye.
Everyone online?
Aye.
All opposed in the room? And online? Any abstentions? And that vote passes. Thank you. And so now we will move on to If the board would like to look into a second option for the I-5 corridor and metro region as a regional plan.
Yeah. And so I would suggest that we do, and I would suggest that the list of additional bullet points is pretty much the same. I just wanted to have a few nuances, that's all.
Could you go back up a couple of slides to the one with the green lines, please?
43.
That's the one. Thank you.
So, so we talked about, Brian here, I'm looking to you again. I'm sorry, I don't have this like error list. We should probably just use the whiteboard and write them down, but basically we talked about a plan, like a 5-year strategic plan, right? And so that's the same, but I just wanted to emphasize that, that is a clear expectation for Kaiser as well. Kaiser's costs have been coming in higher, and we've had many discussions about the efficiencies over the years. And the proposal was not super clear about what are we doing that is different in the next 5 years than what we did the last 5 years, because we can't do what we did the last 5 years again. So that's the plan, 5-year plan. And so that I just want to be sure that that's heard. And so, so there's that. Now, as part of that plan, I would suggest that we have noticed that a good portion, like a noticeable and maybe surprising amount of the total costs are actually going to non-network Kaiser contracts, right? And particularly around behavioral health. So we need to understand that, like, what's the plan? Are we containing costs in those? What is the plan for behavioral health? And we didn't hear that super clear in the Kaiser's proposal. And we want to be clear about that as we go to negotiate, like, what is the efficiencies that we're going to get to? Like, it still feels like behavioral health is an add-on to Kaiser, that these are my words, that it's like being like added on, kind of like, well, I'm done. It's not in the DNA. And it's like, that is an expectation. It's soup to nuts. So what are we going to do that's different? So I'm adding behavioral health as an emphasis point that we didn't discuss. Okay. And then you mentioned that we probably don't need as much discussion about the integration with, you know, the RX external thing, because that's not what we're doing there. So that's that bullet point's not quite, doesn't line up, right? So that's why I'm saying it's a little different. And then I also agree, like the external out of state things, like they, you know, Kaiser's you know, they kind of have that system. So that's not quite the same emphasis either. So what other nuance with Kaiser?
I think that the out of state one is still relevant in a different and weird way,
It's true, like it's unique to them, isn't it?
because they do have other regions that overlap with where,
True, true.
and I don't, yeah.
Good point. We should probably at least just understand, like, so, there was one more. A second. Oh, on the issue of absorbing many new members at the same time. So we probably do need to have them formally kick the tires on that, right? We don't know what that's going to look like, but let's say, I don't know, but like, let's say that there's, I don't know, 20% increase in Kaiser or something like, could they absorb that? Infrastructure wise, as far as administration, I don't really have doubts that they can absorb that, but availability of network, there I have some questions. If they suddenly there was a 20% increase based off of 80,000 people, I mean, that's a different thing. So I think we do want to at least ask them to kick the tires on, like, what would you do? Because I think across the board, all, plans have struggled with hiring, providers at a pace needed, and it's a big shift in the I-5 corridor. So let's ask them. It's a slightly different question, from MODA, but it's basically the same in principle. Okay, I think that's the nuances I wanted to add. Is there something that we've talked about in the last year that, oh, Andy, sorry, I didn't see. Go ahead.
Oh, I just wanted to, I think I'm remembering it right. Did Kaiser commit to the 3.4% or less per year?
So for 2027, their current premium offering is 3.4% above 26. There is a performance guarantee around 3.4% in subsequent years. There's some clauses around what the loss ratios have to be in order to meet that, but yes, there is
Okay.
an offering there.
Great, thank you.
Emily, would you please go to the next slide? Thank you.
So, I don't know if there's any more discussion around some bullet points, but I think,
If not,
Yeah. So
I can take what you said, or you can formally.
yeah, I mean, I'll make a motion that we accept Kaiser regional proposal, which just a reminder, does include both the traditional and deductible planning. With the bullet points that we've discussed, plus the new nuances that we just laid out. For the purposes of staff and Mercer negotiations.
So we have we have a motion on the floor as Sean presented.
On.
Second is that motion. And the motion is that we accept Kaiser into the I-5 corridor metro with all of the nuances from the previous, as well as those that Sean added in our discussion. Is there any more discussion on this vote? All right, seeing nothing in the room or online. All that would like to vote yes, say aye.
Aye.
Online?
Aye.
All right. Any no's in the room or online? And any abstentions? All right, and with that, that passes as well. Thank you all very much. Good discussion. Well needed.
Well, thank you. Actually, I guess we can move on to the next section. So what next, really? Where do we go from here, right? So next slide. All right, Brian, I'll read these, but please step in if there's anything. So next steps. Sending out notices to finalists indicating the RFP results. Then obviously we start negotiations, right? We start discussions around all of those points. I mean, there's a lot of bullet points, there's a lot of issues. They're in the room, so I think they've heard and they understand, but those discussions will happen. We will be working, with the board and board leadership during the negotiations. We will, we have the following we have the two plus, I don't know, Ali mentioned July, if needed, board meetings to kind of bring back points and to make final decisions around that. And at some point we will have the final plan design and rates. We'll have those discussions. We'll, have discussion back and forth with leadership and the rest of the board, and hopefully we will come to a situation where everything's like, we're all happy with it and we can meet the 3.4% and everything else. But don't know the timing on that, but we will work our best for that. Okay, so those are the next steps. Brian talked about this next slide a little bit, slide 49, long-term discussions. And it is, so what, and to reference this point, it's like we have two winners essentially, right? Or I guess Kevlarix is the winner, but two plants. So where do we go? Is this really what the board wants? Do we need additional options per Andy's point, right? Additional options. Do we have differentiators between the plants? And those sorts of discussions, what can we do? What kind of timeline do we have? I mean, I think those discussions will need to happen. I think tentatively, we think November retreat would be a great time to really have those conversations. We're going to be tied up in contracting negotiations in the meantime, but having that discussion for planning so this is our situation where we go.
Yeah, and Emery, I'd just say, I think we want all the board members to just kind of think of these questions going forward. I think, if we forward to the next slide, and maybe let me cover a couple points, and then let's open it up. So if anyone has some immediate thoughts, we want you to be able to share. But depending on how the board feels long-term, if the board is interested in, adding plans or addressing certain gaps based on the results of these RFP, that staff and Mercer can work together to identify some options or strategies for the board to consider. As I mentioned earlier, I doubt any of these options would be kind of could be things that would be implemented right away. We envision that these are things that would need to be developed and take time to kind of vet and to administer. And just for an example, one option could be to consider, a more focused RFP, specific to one or more regions or, specific to a certain plan type in the future. And just that we could plan on having these discussions in the board this fall. And Mercer and staff can continue to gather board feedback on these questions. So with that, I do think we want to go back. This is the last substantive slide, but if we go back to those questions, I think I do want to give an opportunity for any board members, or management leadership to just, are there any reactions you have about kind of the short and long-term picture?
So, just as Andy had said earlier, I mean, I know that we have a lot of members who have a lot of concerns around certainly like being in a plan for a very long time under the Providence plan and losing that option. And we're entering into unknown territory that is hard for people. And people have had choice for a while, like multiple choices. And so really saying it's Moda Providence, Moda statewide or Moda regional, for a lot of people, that's not going to feel like they're getting much of a choice. And it's not just about choice for us. I mean, it's also about like, what do the health plans look like? How are they performing? I am disappointed that it didn't yield more. And I also just really want to uplift Sean and Greg and Andy for like doing all those interviews. I mean, it was an incredible amount of work. So I just thank you so much appreciation around that. And I would like us to see if there's any piggybacking we can do with OEB, because we know that they didn't go through the RFP process. And so would love, Ali, for you to keep us in the timelines on that. And is there any way we can piggyback and say, hey, look at these options that they're looking at the same time for 2028?
Yeah, sure.
And in the same vein, again, gratitude for all the work and really pushing this system to deliver on behalf of members as much value as it can, and bringing the learning from this process and applying it to future state as best we can, including the learnings for each of the proposers that comes out of this RFP, those who did wind up as winners and those who didn't, so that they can take those learnings back, see what they might refine and tighten up for a potential future collaboration, potentially in alignment with other processes to leverage the administrative work, for example, of the OEB needs and rhythms, cadences that didn't line up with ours this time.
go ahead.
Oh, Emily, go ahead.
Yeah, I appreciate this opportunity to share some long-term ideas again. Um, so just, I don't know if this is out of scope, but I would love to look at strengthening our alternative health and healing um, options for members. And, I think I've shared in the past, like, my 81-year-old mother had a couple strokes, and it was just amazing that acupuncture and massage therapy, just regular treatments, how she regained her whole left side of her body. And I would just love to have that be more accessible to all of our members. Cardiovascular disease, chronic conditions, they keep rising and going off the charts. And so, I'd love to, I've mentioned this before, but love to look at that possible gap. I'm not sure because I wasn't involved in vetting these particular proposals, but just, what Siobhan was saying and reminding us, even Kaiser has like alternative options. And then mental health, behavioral health, just like we have such strengths in Oregon and assets that don't, and in the Pacific Northwest that don't exist in other places of our country that I don't feel like we've completely tapped into. So, even with the Native community and the tribes here, our tribal health system in Oregon is one of the best in the country. And so I feel like the tribes could teach us a lot. I also, with our Asian communities, Asian American communities, we're the fastest growing racial ethnic group in Oregon, faster than the national growth rate. And there's a lot of Eastern health and healing that we have not tapped into that others have. Like Canada has an East-West hospital, Hawaii has East-West federally qualified health centers. Like I feel like we could do something there. Also, Washington State and Oregon State, just we're one of the few states in the country where you can have a naturopath as your primary care doc. And so, I'd love to like explore that further for our members, especially our members who want more natural health and healing and less invasive approaches to health and healing, which often are less costly. And so just would love to explore those things and as we look into more culturally specific health and healing options for our members, that could also potentially lead into a more culturally and linguistically competent healthcare workforce for Oregon. And so those are just some ideas that I have for long-term discussion.
Thank you very much. Ollie?
Yeah, just wanted to add, and thanks for that, Emily. Speaking for staff and really being the ultimate optimist, there's really not a lot of disappointment for us. I think, what staff have been through this year and members as well. I think we have two long-term committed partners that, we're just super excited to kick off implementation and negotiations and implementation. And really, I think, considering the partners that we've had over a long period of time, they've always come to the table when needed. And I really do think we'll make this happen.
And Ollie, that's a good point. I think it's fair to feel that, we have some really strong proposals we selected today, but also we wish there were just more options to present to members. I think both are true.
Go ahead, Sean.
Yeah, I was actually going to say something similar. This might surprise you, but I feel pretty hopeful about it. So let me make my case. So first of all, like just recognizing it's going to be a big change, Providence, and that's unavoidable anyway. Like, because even if we weren't doing an RFP, like, it seems like Providence was going to pull out anyway. So that's just happening. Yeah, that's just happening. So that's going to be big. It's going to be scary. And we've already been through a lot. Our members have already been through a lot. So you just have to understand, like, it's going to be scary. I think that there will be some calming down when we see the disruption analysis. And it's actually not as disrupt, like as far as can I still see my doctor?
Right.
And then I think that's gonna be less disruptive than you think. And especially by the time we get done with, negotiations and whatever. So I think that will help calm some people down of just like, well, at least I'll still have my doctor, So there's that. But that being said, that's gonna be big and it's gonna be scary and we just have to accept that. So, it's on us, partially to have a communication plan with our members to just kind of recognize like, yeah, this is big. To talk about the disruption analysis, like, whatever it is, like 95% of you will still have the same doctor. It's not like you're changing doctors. I don't know what the number is. I'm just saying, whatever it is. So there's that. That being said, then, I just want to say, like, yeah, we did open it up for national competitors and like our Oregon plans, like there was no comparison. Like there's a huge difference, So we have some innovation in the state. We have partners that are willing to come to the table and like negotiate and try to do things. We have that relationship. We now have the OEB and PEBB board, which we've been working for a long time to, work on the same kind of cost containment strategies at the same time. And now we have the same statewide, so there's some opportunity there. We have the innovation work group. Not all the states have such a thing, right? So like we have that. We have an incredible amount of like research, development, kind of, brain power to just work through as with the staff, as with the organization. And we got these two plans that can work together, that can help innovate. And so we have actually quite a few tools on the table. We also have at times like a legislature that at certain key moments like has been willing to like try something. We're one of the first few states that try to hospital cap, not the first one, but just like early adopter, let's just say. And so, and we kind of have a pressure to do so, right? So it's a bit of a pressure cooker, which can feel pretty oppressive at certain times. And I do think that the 3.4% is probably a bit much, but that said, that's not my call. But the point is like we've innovated and we have partners that are willing to at least try things and bring things to the table. And when we bring things to the table, they're willing to try it and so on. So that ain't nothing. And so I just want to say like there's a chance that we've got enough tools on the table. We've got, some partners that are willing to give things a try, to put some things in place that can put us onto some kind of sustainable path. And I think that's what we're all up to. And so, I don't know, I'm leaving it as a possibility that, some things might fall into place.
Thank you, Sean.
So
So are there, oh, go ahead.
Sorry. So I just wanted to add, we've experienced some kind of interesting times lately. And what I think is key about the PEBB board, and again, I'm not OEB, so it's probably both boards, but I'm going to speak specifically to us because I think I've been here 7 years or something now. But the PEBB board, we take our roles very seriously and we take our relationships with our providers, our members, our providers, our networks very seriously, which is why we got a little worked up over what's been going on recently. And I've been the number one squawker. But what I think has shown is we've built these relationships based on mutual respect and trust. And we've continued that as we work through we will negotiate and work through, and we will continue because it's really important to this board. And that's what makes us who we are. So, yeah, I just really think that speaks volumes for all of it, right? Every bit of this, so.
Thank you, Kimberly. Brian, go ahead.
Well, I was just gonna ask if there are any other, comments or remarks before we close the meeting.
Any other comments?
If not, Emily?
Emily?
Yeah, just one final little detail I forgot because of our emphasis on mental health and behavioral health statewide in Oregon, which I think is great. Also, when we're talking about natural health and healing, some people have really deficient vitamin D levels that really cause a lot of depression and suicidal thoughts, and really low B12 levels. And then that also has to do with our climate, and not always getting enough sun. And so anyways, I just wanted to make sure to include that example as well because of our emphasis on mental health and behavioral health in Oregon being a top health priority.
Thank you, Emily.
Mhm.
So I would like to take just a minute to thank everyone. So PEB staff, Mercer, board members, for all the folks who have participated in the process. We've had an advisory work group that staff and Mercer have been using to help vet this information and identify these considerations and make sure we can work through them in a way that is meaningful. We also want to thank all of the proposers, not just the folks that were selected today, but for everyone who submitted a proposal. We want to thank you because, again, we understand it took a lot of time, effort, and resources on your end. And for the ASPs, we look forward to partnering with you and to continuing discussions related to implementation and negotiation. And just to reiterate, as Ali mentioned at the beginning of the meeting, the RFP rules of communication are still in effect, at least until we come back to the board at a later time to ask for final approval on plan designs and rates. So staff and board members should not have RFP related discussions outside of these sanctioned meetings or other meetings sanctioned by the RFP team. And then proposers should continue using the single point of contact through the RFP and should not reach out or communicate with staff or board members about the RFP. So with that said, I think we can adjourn if there are no other final thoughts for the good of the order.
A quick question, Brian, is this slide deck going on public record so people will know the Mordekaiser, even though they won't know the weeds? Because those are
So we will post the PDF presentation. I don't know if our comms folks are on the call. I don't know what the process is for how long it takes to post, but we will send them to, or I will send the presentation to the comms team shortly. And at some point, relatively soon, it will be posted. And as Ollie mentioned, if you do get contacted with any RFP related questions, you can just say, we're not allowed to discuss, but we can, send you or point you to the presentation that we went over today.
Thank you.
All right. Anything else for the good of the order? All right, then if you're in Salem, it looks like we could go get some of that vitamin D. And I would adjourn the meeting. Thank you.
Thank you.
Thank you, everybody.
Thank you.